We already talked about Addison and Cushing. Now I was talking about potassium. And what did we said here? No P means when urine output is low, what would be your potassium is high. So remember, doctor has ordered, and usually they use the word like KCl. KCl is potassium. K word is potassium. Everyone for our exam, we must know your normal blood level, your electrolytes. Very important. I'm telling you, every day, start memorizing your labs. And what happened to the patient when you're giving potassium? They're not asking anything, but the question, doctor has ordered to give potassium. What do you do before you give potassium? Always, what would you do before you give potassium? Check for renal. Everyone is okay? Maybe your answer is check the urine output. What do we check on renal? BUN. And what do we check here? Creatinine. And what would happen if potassium level is high? That means your potassium is high, your kidneys are bad, and your BUN would be high, and creatinine would be high. Everyone is okay? And what would be the urine here? Urine output would be very low. So before you give potassium, what do you check? Kidneys. They're not asking straight question. Maybe you have lab, and they have in the lab is potassium level, and they have in the lab is your creatinine level. So whenever they're using the word, what is the word is nephrotoxicity. What is nephro means? Kidney. What do you monitor before you give potassium is kidneys. And what would be high in the lab here? Creatinine, and would be high here, the BUN. Everyone is okay. Let me take you back here, another question. Patient has DKA. What is DKA? Diabetic ketoacidosis. Now, a lot of time when you see your question, what do we feel? Oh, we need to monitor ketoacidosis in the urine. Always remember, what is DKA? Sugar is very high. What is the patient is having here? Hyperglycemia. What are you going to do the first thing? You're going to give insulin. And what would you monitor for your patient? Now they are asking you, what would you monitor your patient is your potassium level. Why? Because what does the patient has here? Polyuria. So remember, diabetic patient has what? Polyuria. You are giving Lasix. What are you monitoring? Potassium. Why? Because we are losing potassium. And when you pee more, you are losing potassium. Second thing I will remind you, whenever your potassium level is bad, that means it's affecting your kidney. So we are looking on kidney. Whenever your potassium is high, remember, don't give salt substitute because they are high in potassium. So everyone, you can add there, do not give salt substitute when your potassium is high. Everyone remember the word nephrotoxicity. What is nephro means? Kidney word. And what are you monitoring? Don't give the drugs when your kidneys are bad. So everyone is okay? Potassium level is high when your kidneys are bad. No pee, potassium is high. You pee more, your potassium is low. And don't give your patient salt substitute. A lot of questions on that because that is high in potassium. Now I'm going to go elevate vein in the next one and dangle the arteries for perfusion. What is the meaning perfusion? Circulation. Improving circulation for the artery and the venous problem. If you have vein problem, elevate them. Arterial problem, you are dangling them. So that is important to memorize, arterial and venous circulation. And perfusion word is to improve circulation if you have arteries problem or the venous problem. Next word, you guys have the word APGAR. Where do we remember the APGAR word? APGAR scoring. When do we do APGAR scoring? for the newborn babies, and you're assessing how the babies are. So what do you monitor in APGAR scoring are? Number one, A. What is the A means is, what is the color of the baby is? How does the color look? Number P, on P you will go, is the pulse rate. You do need to monitor the pulse rate. Is lower than 100 is not good. And also if it is more lower, it's not going to be good. Grimacence, how does the child is responding? Is coughing, responding. A, activity. Activity means is the muscle. Muscles, you look, the word is the called flaccid. When the muscles are weak, we call the word flaccidity. And R means is respiration. When they're saying strong cry, baby is good. Weak cry, baby is not good. So what are we monitoring in APGAR score? What is the good APGAR score would be? What is the good APGAR score? 8 to 10. I want you to add there, 8 to 10 is good. Do you have to do anything if the APGAR score is 8 to 10? No. Which is the bad one is here. I want you to add there, 0 to 3 is very poor scoring. When you have a scoring in your question and they're saying child APGAR score is 0 to 3, very poor. Which is the one is good? We said 8 to 10. Now what happened between 8 to 10? You still need to monitor the child. So I said 8 to 10 is good. You don't have to do anything. But between 4 to 7, what do you do if they give you 4 to 7? You still need to keep the baby warm and maintain them less activity, and that means you are monitoring them for respiration, keeping them warm. You are still assessing the child. Everyone is all right? APGAR score, normal. You got to know, 8 to 10, good. You don't have to do anything. 0 to 3 is poor. What do you do? Resuscitate. Write down the word resuscitation. Child is not going to survive. We got to do what? Resuscitation. Now, I will move on. So we all need to. This package is combination of everything. So whatever it comes is good for our knowledge, goes in your OB question, maybe on PEDS question, the baby is born, and you're assessing APGAR scoring. Child has 8 to 10, you don't do anything, is fine. 0 to 3, resuscitate. 4 to 7, you still monitor, keep the child warm, and continue observation because they are not in a complete very good scoring. I will move on to the next word, transmission-based precaution. Now here you don't have all of them, but why I like you to connect, and I gave you the page with isolation. Now remember, it says here, transmission-based isolation. I want this paper, if you guys will keep closer, and see there is a airborne precaution. Everyone should know, number one, airborne precaution. In your Spiderman package, you have measles, you have chickenpox, you have shingles, you have TB. And all of them will go in what? Airborne precaution. In your package, it says how to memorize. In Spiderman package, it says MTV. Highlight the word MTV. M, measles, T, TB, and varicella, chickenpox and herpes zosters are with viral infection. So you have on your Spiderman, the word is called is MTV for airborne precaution. Now, if you look now on this page, I want to show you a few things because we must know how we are looking the precaution. So let's see this page, and here it says airborne precaution. Everyone look on this page, and it says measles, TB, varicella, chickenpox, and shingle. Everyone should memorize. And if you go in the last paragraph, in the bottom of the page, is there are pressure. What pressure are you going to give? Is negative pressure. So what pressure we are giving here? Negative pressure. That's important because that can be asked. Then you move up. It's a door. We have closed the door. So if you have airborne precaution, they're going to ask you, where would you put them in the room? You're putting in a separate room. Are you going to close the door? Yes. Are we going to, what pressure are we going to apply? Negative pressure. Then they will ask you, what would you use? What is it important here to use is the mask. What kind of mask we use it? N95 and particulate mask. Now if they give you a question, you have a TB patient and you are going to give bath or you're going to do your patient care. What do you wear now? You got to wear your gloves and the gown. But what is it very important here is only the mask. But if you're doing a patient care, yes, you need to wear your personal protective equipment. Everyone is okay? Airborne precaution. Everyone know no other pressure we have. Only one negative pressure, and that negative pressure would go for where? Your airborne precaution. Door are going to be closed. And what mask are we going to use? N95. So remember the word airborne. Now let me, since I'm on this page, I want to show you reverse isolation. So reverse isolation, if you go in the bottom, what does it say in reverse isolation is positive air pressure. Everyone should know when you're putting a patient in reverse isolation is only positive pressure. So we have two pressures here, negative and one is what? Positive. Where do we put negative pressure? Airborne. Where do we put positive pressure? In reverse isolation. Now which are the patients in reverse isolation are? I will read here because you may not have on this page, but everyone should pay attention and make sure you memorize your isolation. Very important for us as nurses to know. Number one, white blood count is low. They give you a question, the normal white blood count we must know, 5 to 10. And if they give you 2,000, 3,000, what do? They're not going to ask you anything, but they're giving you the lab. And lab, you're looking, the white blood count, that patient is going where? In reverse isolation. Third one, everyone should know, only one anemia. It goes in reverse. Which anemia goes in reverse here? Aplastic anemia. Why aplastic anemia? Because they have bone marrow affected. What is in bone marrow here is white blood count, the red blood count. No other anemia patient you're putting in any isolation, only aplastic anemia. And remember, aplastic anemia is important to know. Why? Because it affects the whole bone marrow. Are we clear? So anemia, burn patient, AIDS patient, they have very low resistance, you can put them. Cushing. Rheumatoid arthritis. Why? Because they have very immune system low. SLE, serum lupus erythematosus, goes in reverse. Why? Because they have immune system. What is serum lupus erythematosus? The ones they have the butterfly rashes, but it is a immune system. Everyone should know. These are very important to know in reverse. The last one, you have strict isolation. A strict is almost same as reverse, but who we are saying strict isolation are radiation patients. So, and what do you do for them? You close the door. All three of them, remember, three patients, what you're putting in, your airborne, your reverse, and your strict, three of them all have closed the door. And that they will ask you in the exam. What do you need to wear? A special apron. What are they going to use here? A special forceps to pick up the radium. Now 6 feet, you have no other patient, but what is the distance of 6 feet here is between the patient and you. Everyone is okay? So patient is alone. What is the distance when you're going in patient's room? You should be away. When patient has a radiation, you don't want to be close. So remember, this distance is what? For us to be far or the visitors not to be close. And when you have radiation, you don't have two patients, one person alone. Are we clear? So those are, and 6 feet distance, closing the door. Any pressure? No. Everyone without looking, we should know there are negative pressure for which patients are airborne. Which one you have positive pressure, reverse isolation. And who you are protecting in reverse isolation, the patient, they have low resistance, and those are we need to memorize. So that is on there. The next one, I want to see contact precaution. How you are looking, and then I will go back on a Spiderman package. Let me just show you how everyone should start looking the isolation question. It says contact. Contact precautions, you have MRSA and VRE, and they have been, the word they use, colonized. Sometimes they throw the word colonization. So I want you to write down the word colonization. That means they still have those bugs, but it may not be the dangerous. So they have MRSA and VRE, vancomycin resistant, and C. diff, very important, we all know C. diff, and RSV, and hepatitis A. No other hepatitis, only hepatitis A goes in contact. Why? Because the infection is from fecal oral, by hands. And impetigo, integumentary system, we did yesterday. We talked about impetigo, scabies, and lysis. So remember, all your wound infection, any stomach infection, any eye infection, all are going to be where? In contact precaution. What do we remember here in contact precaution? Using your personal equipment, your gloves and gown, and blood pressure cuff, every disposable thing, and you are not moving anything from patient's room. Very important, that part, especially the blood pressure cuff. You have done the blood pressure. What do? You have to take the blood pressure for other patient. Do not move. Leave that blood pressure cuff in the room. Anything came in patient contact should stay in the patient room. Can you put two together? Yes, you can put two together here. Between the patient distance should be 3 feet. Minimum can be 3 to 6 feet. So can you put two together in contact? Yes. Are you going to close the door? No. Leave the door open. Any other pressure you require? No. Everyone is okay. Contact precaution is what are we using? Personal equipment. Do not remove anything and start looking. What is your contact? Your wound infection, your GI problem, all those would be pediculosis or impetigo wording. Let's go droplet. Droplet, you have a lot to know. And a lot of questions will come in your droplet precautions and contact precaution. What is in droplet? You have pneumonia, meningitis, mumps, German measles, flu, pertussis. Pertussis is called whooping cough, and diphtheria. And what do we use? What kind of mask do we use in droplet? Regular surgical mask. Can you put two together? Yes, droplet you can put two, same kind of infection you can put together. Remember, leave the door open. You don't have to close, only we were closing the door, airborne. Droplet, you leave the door open. Any special pressure you require? No, only we said two pressure, negative and positive, no other isolation. So droplet, you're going to go for pneumonia, meningitis, mumps, German measles, flu, pertussis, diphtheria. And I will show you in Spiderman. You have more. So I want you not to forget looking in Spiderman, and I will make you highlight some of them very important. Last one, standard. You don't need to memorize standard. All our patients are standard precaution. Are we clear? Now they have given the names here, but every patient you are treating are a standard. What is a standard precautions are? What is a standard means are? What is our standard care of your patient are? What is our standard precautions are? How do we treat our patient? When you come in contact with body fluid, you're wearing the gloves. When you're using your sharp needle, that's your standard, that you don't pack those and dispose them in the biohazards container. So what is a standard? You're coming your patient body fluid, whether it's a blood, whether it's a urine, whether it's a feces, that goes in standard, that you wear your gloves, you wear your gown, and remember is splashing. Everyone remembers, suction can cause splashing, emptying the Foley catheter can cause splashing. So remember, what do you use to protect them? Your eyes, and use that goggles maybe. And so remember, these are some of your precautions. So keep that. I will move on a little bit on Spiderman package, and I want to show you on droplet. We are still on page 1. And droplet precaution, we already had talked about MTV, airborne, and let's go where it says droplet. Think about Spiderman. And they use the word Spiderman to define what kind. If you can memorize all of them, I want you to highlight the word scarlet fever. Everyone should know scarlet fever. In S is sepsis, scarlet fever, streptococcal infection. You have pneumonia, very important, we all should know. Pertussis is called P, and in pertussis we call whooping cough. Make sure we know the word. Sometimes they give pertussis, sometimes they will use whooping cough. Influenza, you don't have in there, so make sure scarlet fever, influenza, diphtheria, epiglottitis in the children, in the peds, I will be talking about. Epiglottitis comes here, mumps, meningitis, and in the last it says private room, and you can, in the droplet, you can put two together, the same kind of patient. Now let's move to page number 2, is telling about your contact precaution. What is in contact precaution? Remember the word Mrs. V. And Mrs. V, you have M, multi-drug resistant, respiratory infection, as skin. So remember your skin problem, your wound, enteric. What is the word is E, enteric. Enteric means GI. Whenever you have a stomach problem, that goes enteric. Clostridium or C. diff is enteric. Patient is having diarrhea. It's like colitis. And E means eye. So remember, in contact, is sometimes they will use the word patient has enteric precaution. Enteric precaution means they're having what? Stomach problem. They're having a diarrhea and colitis maybe. And eye means for eye infection. In the skin, they have given is varicella and zoster. Cutaneous. Diphtheria goes in droplet, but if they're using the word cutaneous, cutaneous means the skin, and that is going in contact. Impetigo is skin. Pediculosis and scabies will go there. So look on that. Any questions you guys have, you can always ask me later. And so just look. I want everyone remember, 80% in exam, your questions are going to be isolation, placement, and looking your patient. What is looking in your patient? We need to know the labs. So very important, everyone keep these pages together. And now I'm going to move on page number 2. Very important information is number 1, it says air embolism. And it says slash air and pulmonary embolism. Now what is the meaning here that air embolism, if patient has, it can lead to what? Pulmonary embolism. Now, let's go first, air embolism. How do you get air embolism? Now, when I'm talking in renal, those who have done renal with me, and those who haven't done, we are going to repeat again. And so what is in renal when patient is going for dialysis? And what kind of dialysis? I want you to remember the word hemodialysis. There are 2 kinds of dialysis, peritoneal dialysis and hemodialysis. So what dialysis complication, this air embolism, is hemodialysis. So remember, everyone, make sure we know, because when I'm talking in renal and dialysis, I say, what are the complications of hemodialysis? One of them is air embolism. Patient is in dialysis and patient has air embolism. what would you do? You got to do something in your question. So let's see in the second line. Immediately when they're asking you what would you do when patient has air embolism, you are preventing them going into the pulmonary embolism. So what do we do here? In second line, this is your answer to prevent air embolism. Turn your patient to the left side. What side are we turning? Left side. And what do we do here? Lower the head of the bed. So this is your answer for preventing air embolism. Everyone is okay? What do we do if we have air embolism? Is turn the patient to the left side and lower the head of the bed. And if you don't do it, and what does it lead to? Pulmonary embolism. I want to remind three things here, because I want to remind you that we must know how do we get. I talked about air embolism. That is one reason patient can get pulmonary embolism. What are the other reasons are? Number 2, fat embolism. Those who have done with me, good, and I want you to write down like this so you can remember. Is very important, your pulmonary embolism. Pulmonary embolism comes from fat embolism. How do you prevent fat embolism not going into pulmonary embolism? Your answer, first thing is, when patient had fracture, immobilize your patient. So write down the word immobilize. So what did we do here? Immobilize. What is the meaning immobilize? Don't let your patient move. And you are using something to immobilize. Number 3, DVT. And before DVT, what do we get? Thrombophlebitis. So how do you are preventing your patient here? You are preventing, first thing, thrombophlebitis. And how do you prevent thrombophlebitis? Ambulation, your patient. Which patient are high risk here? Those who are laying in bed, patient who come back after abdominal surgery and hip surgery. And that is important to know. And once you have DVT, is already the clot is there. Now you don't want the clot to dislodge. And what will happen is going to go into pulmonary embolism. Everyone is okay? How do we get pulmonary embolism? Number 1, air embolism, fat embolism, and thrombophlebitis and DVT. And DVT also, once the clot is there, if it is lodged, we are going into pulmonary embolism. I don't like just reading these 2 lines. I want you to connect your question. Your questions are going to be prevention. What did you do for air embolism? You turn the patient, and on the left side, lower the head of the bed. What did you do for fat embolism? Immobilize. What did you do to prevent thrombophlebitis? Ambulation, exercise of leg to prevent your patient going into pulmonary embolism. Now, what happens if your patient has pulmonary embolism? I have talked this in respiratory. Remember, everything we got to connect. Now, what would you see in your patient when they have pulmonary embolism? I want you, this is the way we talked before, and I want to remind, is pulmonary embolism. What is the first thing patient has? Is hypoxia. Everyone remember the word? When pulmonary embolism happened to the patient, what are they not getting? Oxygenation. So remember, simple thinking is here, hypoxia word. What is second thing you will remember is they have lack of oxygen. What is the first sign lack of oxygen would be? Restlessness. Everyone should know. Your question, what is the first sign of lack of oxygen is? Restlessness. What is the late sign of hypoxia would be? Cyanosis. Maybe patient is saying dyspnea. Maybe chest pain. Why? Because that's the later sign. Are we clear? See, if you will see your question, you're going to see pulmonary embolism. Maybe they had chest pain, maybe they had cyanosis. But if you're looking, that is a little later. But yes, that's one of the signs. But how do we memorize here? Is number 1 is we call hypoxia. What is hypoxia? Early sign of hypoxia, your patient is start getting restless. And then what happened to them? Their color is changing. And they're complaining chest pain. and they are having cyanosis and dyspnea. Number 3, I want you to hypoxia. Number 1, patient has restlessness, and this we said. Number 2, patient is going into shock. What is the symptom of shock? Are low blood pressure, pulse is high, respiration is high. Everyone is okay? And they may not give all the symptom. They said patient is going in pulmonary embolism, patient has cyanosis, chest pain, tachycardia, tachypnea. Are we clear? But you remember, how do we remember all the different vital signs? Where does it go? Remember the wording. Patient is going in shock, patient is having lack of oxygen. Now I want everyone to remember earliest sign of pulmonary embolism. What is the earliest sign is here? Petechia. Petechia where? Over the chest and the shoulder. It's an embolism and lot of question. Patient fell, patient had fat embolism. What would you observe in your patient? They have what? Petechia. That's early sign. That means patient is going into pulmonary embolism. What are we going to do to prevent your patient? So everyone is okay, these 3 wording here. Number 1, hypoxia. Number 2, shock. And number 3, I said petechia, that comes before even you start seeing those symptoms. So patient is going to be. Now I'm asking you, what do you do if we have question, patient is having pulmonary embolism, and what would you do as a nurse? Raise the head of the bed. Everyone, as we are nurses, we don't need to call RN. We can go there, and what do? We raise the head of the bed. What do we do? The second thing here. Oxygen. Oxygen. How much oxygen do you give? 100%. Remember, your nasal cannula does not give enough oxygen. So if you have cannula, don't pick up that. But what do we pick up here? Mask. What medication do you think they will give for embolism? In your questions are going to be maybe heparin. You can give heparin IV, and they can give you streptokinase. What is streptokinase is? What is streptokinase is? Thrombolytic medication. What is the meaning thrombolytic? It's dissolving the clot. What is heparin? Comes more preventing more clotting. Are we clear? But you can give heparin IV, and you can give streptokinase IV. See how your questions are. We got to know all pulmonary embolism. How do you get it? How do you prevent it? Because we are nurses, your questions are going to be prevention. And what would you do as a nurse? What do you monitor? Another question, your patient is on heparin, and this, what do you prevent here? What do we prevent here? What do you monitor your patient? When you are giving, these are bleeding. Very good. What are we monitoring here? Bleeding. Are they going to give you a straight answer, bleeding? No. How do you know your patient is bleeding? Hematuria. What is hematuria? Blood in the urine. Patient is having hematemesis. Is blood in the vomiting. And what else they can give you? You receive the result of guaiac stool and is positive. That means positive guaiac stool means is for bleeding. Are we clear? So patient has been bleeding. Everyone is all right, pulmonary embolism. And I like you to completely covered it. So you guys all we know whether you have heard respiratory or not, but we must know pulmonary embolism is very important. And these are the 3 things. Number 2, I'm going to move on. Number 2, on your package, it says woman. That goes in OB. Woman in labor with unreassuring fetal heart rate. And it says late deceleration in the next word, or decreasing variability. Fetal bradycardia. So meaning deceleration means bradycardia. There are 3 deceleration we have in OB, And when we will talk about that, there are early deceleration, variable deceleration, and here you have late deceleration. I want you, everyone, to know the word. Why do you have late deceleration? Is mother is coming in and mother has late deceleration. And what would you do? I will read later. But first thing, what is the late deceleration mean? There's mother is bleeding. Are we clear? And what is the reason for bleeding? Which one is more is on the bleeding is abruptio placenta. Or they can use the word placental insufficiency. What is the meaning placental insufficiency? Placenta is not getting enough blood. They didn't use the word abruptio placenta. And they said mother is admitted and mother has placental insufficiency, meaning mother is bleeding. Are we clear? So what is late deceleration comes from bleeding. So what do you monitor for your mother here in your answer? Second line, turn the mother on the left side. You are increasing perfusion for the baby. Give oxygen, stop pitocin, and increase IV fluid. Maybe also they can say increase maybe blood transfusion. Mother is bleeding, may be given. Monitoring the vital signs. So everyone is okay. Number 2, mother is admitted. The fetal heart rate is having deceleration. And what are the fetal heart rate deceleration, late deceleration? Reason is bleeding. Everyone is okay? Another word I said, placental insufficiency. Wherever they give you the word placental insufficiency means the placenta is not getting enough blood. That means the reason is mother is bleeding. You've got to prepare the mother also for delivery. And maybe you got to stop the pitocin answer, turning the mother on the left side. So these all intervention we can do. Number 3 is decreased level of consciousness. Now, I'm not going more on decreased level of consciousness, but let's just remember, whether your patient is conscious or not, think about the tube feeding. When your patient are tube feeding, what are the tube feeding do we have? NG tube feeding and G tube. What is NG? Through nose, and G tube is gastrostomy tube feeding. Now here it says position right side. Anytime, which side do you turn for your patient after feeding? Always good to turn them for right side. So remember that, whether it's a tube feeding or, but next line, elevate the head of the bed. Very important. And why do we elevate the head of the bed? You all know, to prevent aspiration. Why? Because the risk is pneumonia. Patient is getting tube feeding, and what happened? A lot of time in real world, you see you do the bed making and you forgot to raise the head of the bed. So as a nurses, we all need to remind each other, whether you have UAP or CNA, that all the time the head, if you keep them flat, what happened? The food is going to be, the feeding is going into the lungs aspirated. Now, in your question, how far do you raise the head of the bed? So if you have continuous feeding, the meaning continuous feeding, you are feeding through the pump. Then what would be your head of the bed? Semi-Fowler's. If you are giving bolus feeding, then should be your Fowler's position. Everyone is okay. Bolus, why Fowler's position here? Is because bolus, you're giving a lot of feeding in one time. What are we giving here? A lot of feeding in one time. So what happened? The stomach has a lot of formula in there and they can aspirate, and it will take a longer time. Now when you're giving continuous feeding, it's going through the pump, going very slowly, maybe 30 to 45 cc in an hour. Are we clear? Now here you are giving maybe 200 to 300 cc in one time. And you're using a syringe, or maybe you can use a bag, but it will go faster. So remember, 2 wording, everyone should know. In your Fowler's position, any question, bolus feeding. Semi-fowlers, you're going to go for continuous feeding. I want to attach a few more questions here. What is the highest priority as a nurse if you have a patient with the tube feeding and patient is not eating anything by mouth? Is oral hygiene. And how frequently you should do the oral hygiene is every 2 hours, not shift by, not once a day, every 2 hours oral hygiene. And what would be, how frequently do you change the tubing for your if you have a tube feeders? And when do you change all the tubing? When do we change? Once a day. Everyone should know once a day. Everyone remember the word residual. What is residual? Before you feed, what do we check? We aspirate. And how much do we hold the feeding? If they have 100 or more than 100, you're not going to feed the patient. If less, then you continue feeding the patient. Everyone is okay, residual, changing, positioning. Where do you keep the formula? Where do we keep all the formula? Room temperature. Only the one I want you to add there, TPN, you are keeping in the fridge. But your regular formulas are in the room temperature. What do you check on your formula? Expiration date. Make sure expiration. What is the highest problem or the complication for your tube feeders are? What is the most complication? Diarrhea. Some people cannot tolerate that. Then they have to try different formula. So a lot of time patient is diarrhea, and everyone should know you're changing the tube feeding. Where do you keep your formulas? In the regular room temperature. Always make sure you're checking the expiration date. So we talked about something about the tube feeding. We all should know what do you do on your tube feeding patients are changing the tubing and keeping the head elevated. Are you going to do INOs? Yes. You have to keep INO because doctor has ordered how much formula, and it's important that we keep intake and output. Number 5 is here, number 4, epidural. Epidural is in your OB question. Position after epidural, so during procedure, during epidural is sideline position. Number 5, lumbar puncture. When do we do lumbar puncture? What do we do? In your, I will read the line, but I want you to add everything here. It says here, oil-based myelogram. Lumbar puncture and myelogram is same. Same means they are inserting into the lumbar spine. But myelogram goes for muscles. Lumbar puncture, what are we doing here? We are removing cerebral spinal fluid. Myelogram, you are assessing the muscles. But they are same. So sometime in your question, patient is scheduled for myelogram. What do you tell the patient? It's like a lumbar puncture. Maybe your answer. Are we clear? But myelogram has nothing to do with lumbar puncture. But lumbar puncture, you are injecting the needle in the lumbar area, L3, L4, and you are taking out, what fluid we are taking out? Cerebral spinal fluid. What are we looking for lumbar puncture are infection in cerebral spinal fluid. Which patient are we going to do lumbar puncture? For patient with meningitis. Maybe a lot of time we don't know patient is running fever, so they're looking all the tests and maybe they may have to do the lumbar puncture. Are we clear? So fever, any unknown, we don't know the reason of fever, maybe they have to look patient with meningitis, and meningitis you're going to do. So it says here myelogram. Everyone is okay? Myelogram is a different test, but they are similar way they're going into the lumbar area. And then it says here, is patient lies flat. Underline that word, that's good. After the procedure. Why? Underline the word to prevent headache. So what position do you do after lumbar puncture? Is on the back. And why? To prevent headache. Now in your question, if you have, patient has lumbar puncture done 2 weeks ago or week ago. Patient is complaining headache. What would you do? The first thing, now don't say call the doctor. The first thing you can do, lay the patient on the back, because maybe, what is it? Leakage of the fluid. And that may be leading to the headache. So what do you do? The first answer here, let the patient lay on the back. And so what position after lumbar puncture is on the back? Now I want you to add completely. And what do you do before lumbar puncture? I want you to add there, number one, consent. You got to get the consent. Then what do you tell patient before lumbar puncture? Empty the bladder. That is important. So empty the bladder, you guys can write it, number two. And during the procedure, position. What is the position during the procedure when you're doing, what position do you put the patient on? Fetal position. This is the best. What is fetal means? You are bringing head close to the knee. So when patient is laying, patient can move themselves, but sometimes we have to help them to bring more their head closer to the knee, or sometimes they draw the knee close to the head. Are we clear? Why? You are making an arch so the needle can go in the back easily. So fetal position. But some question, they may use the word sideline position. But really, when you turn them on sideline, you will not be able to insert the needle unless you have good fetal position. Those two words are very important. So let me repeat here. Lumbar puncture, we are removing cerebral spinal fluid. And what position do you do is during the test, fetal sideline. Before the test, empty the bladder. After the test, what do you do? Is patient should be laying on the back. Why? To prevent the leakage of fluid and preventing the headache. So everyone is good on that lumbar puncture. Next is number 6, heat stroke. What is the meaning heat stroke? You're losing fluid. Write down the word dehydration. And what position, and they have added here, is the position is flat and elevating the leg. What is that word is called? Trendelenburg position. Are we clear? And what is the new word we use? Modified Trendelenburg. Not too high, modified Trendelenburg position. So that is your answer for positioning the patient, Trendelenburg position. So everyone is okay. I will move on, number 7. What is number 7? So remember, heat stroke means dehydration. Dehydration means hypovolemic shock. And that is why you have the position is what? Is Trendelenburg position. All right? Now, next is continuous bladder irrigation. Continuous bladder irrigation. Which patient do we do continuous bladder irrigation? Patient with TURP. You guys all know that. What is TURP is? Removing the prostate gland. So I will leave this word, but I want to everyone understand. If I read these 2 lines, you will not understand correctly. So let's see, what is CBI, continuous bladder irrigation? In your question would be patient with TURP, T-U-R-P. What is TURP is? Removing the prostate gland through the urethra. Transurethral resection of prostate gland. So they're removing the prostate gland, but they're going through the urethra. I'm going in another question. I will come back on CBI. But what is TURP is? Patient is coming back after they remove the prostate gland. They're asking you, what would you monitor your patient when they have TURP? What is the biggest problem here is number 1, bleeding. So what is you need to monitor as a nurse? Bleeding. We need to know. When they're giving you a question, they know you guys have studied this. But how do we remember all these things? So remember, TURP patient, you are very much, you got to monitor bleeding. Second thing is, patient is coming back with 3-way catheter. Foley catheter has 2 ends. This catheter has 3 ends. And what are those 3 ends are here? One for urine to drain, and second one for irrigation solution to go in, and third one is inflating the bulb. We got to know. Patient come back and patient has what kind of catheter? 3-way catheter. And what is the 3-way catheter means is one for urine, one for irrigation, and one for inflating the bulb. Now you guys all have seen Foley catheter has only 2 ends. One for bulb and one only for urine. You cannot give them continuous irrigation. So the meaning is here, this end you are attaching the irrigation solution. Irrigation solution is going and washing the bladder and coming out through the urine. Everyone is okay? That is continuous bladder irrigation. When you take a syringe and you wash one time, that's not a continuous irrigation. That means like an IV, we have to hang a big bag of saline or solution what the doctor has ordered, and they will tell you how many cc's per hour you're giving, and we don't have to do anything. 24 hours it's going in the bladder, and what is the purpose is here? Washing out the bladder. And what are we washing out in the bladder here? The clots, the blood. Otherwise, what would happen? The catheter would be blocked. Everyone is okay? Patient is coming back with TURP. What are we monitoring? Bleeding. What kind of catheter patient has? 3-way catheter. Patient start bleeding. Your question, forget about all this. Your question, patient has TURP. Patient start bleeding, and you will see a lot of blood is coming out in the catheter. What would you do? They did not explain you anything because they think you should be knowing. And the answer may be call the doctor, call your RN, check the order for irrigation. Wouldn't you check the order for irrigation? Because the doctor already sent the order with you. Doctor already sent the patient with what? 3-way catheter. So never pick up, because when we see the blood, we always choose, oh, patient is bleeding, we need to notify. No, we are the nurses. We have to have critically thinking. And we should know, what are we checking here? Check the order, or maybe start irrigation. Are we clear? Another question. I'm already talking to you guys how you should know. Patient says, why are you giving me irrigation? How long are you going to give this? And how long I have to lay in the bed? What would be your answer? Until your urine become clear or pink color. Everyone is okay? Pink is a good color, but if they're saying red, that's not good. Pink color or clear, then we will stop. Usually 48 to 72 hours, depends how your catheter is clear. Everyone is okay. Now these are your questions with what? TURP. I will move on now, continuous irrigation. If you have question on continuous bladder irrigation, that means you're giving irrigation. I will go on the last thing attached here, which you have written, but that would be the next thing. But what would you monitor when you're giving too much of water? It's called water intoxication. You're giving too much of fluid. What do you monitor, patient here? Water intoxication. Too much of fluid leading into water. What is water intoxication? ICP. What do you monitor here? Level of consciousness. What are you preventing here? Seizure. Are we clear? So water intoxication. Patients start changing level of consciousness. Patient vital signs are changing. What are you monitoring your patient? ICP. What is the complication of this fluid is water intoxication. Everyone is okay? What is the complication is here? Water intoxication. How long you will do the irrigation? Until the urine is clear. if they give you a question. You have bright red color is in the urine, increasing. What do you do? Bright red, fresh bleeding, notify the doctor. Are we clear? So what do you do? Bright red color is notified. That is sign of bleeding. Bright red color, sign of bleeding. Increasing clots. What do you do? Maybe increase the flow of irrigation. Or maybe you stop irrigation and take the syringe and flush it with your hand. So what are you doing? You're clearing the catheter. Are we clear? So you got to start reading and apply your knowledge. There's no such thing memorizing. As questions are thinking process. So what do we do when the clots are there? You can irrigate with the syringe. Are we clear? Why? Because when you're giving with this irrigation, it may not go with fast flow, but you can take 50 cc syringe and you irrigate the catheter. So that's your answer. Another question. Intake and output. How do you maintain INO? You used irrigation solution 300 cc in your shift time. When you empty the bag, urine has 800 cc. What is your output would be? You minus this, because that's not the urine. So 800, because this fluid is mixed. Any question, anytime, irrigation solution, whatever you are inserting, you got to subtract from your output. That would be your correct output. Everyone is all right? So what is the treatment for your patient with TURP is continuous bladder irrigation. Let's go back on the page. Now we will highlight the wording, what you have in the pages here. It says, catheter is taped to the thigh, so the leg should be kept straight, no other position. I want you to write down the word traction. So what are we applying here? Traction. So two things with TURP patient is, number one, continuous bladder irrigation, and number two is applying the traction. And don't remove the traction until the doctor has asked for it. And why is it applied? Again, to stop the bleeding. Are we clear? And what do you do when they're saying, what would you do when traction is applying? Then your answer would be, tell the patient to keep the leg straight and tape the catheter. Everyone is okay? And what is the word I said here? Applying the traction. So what are the two things we remember here? Patient has continuous bladder irrigation, and patient with which patient you're going to get it is after the TURP surgery. TURP is complication is bleeding. What is the complication of irrigation is water intoxication. Everyone is all right? I will move on next, number 8. Meningeotomy is ear surgery. And what side you turn the patient on affected side, so it allows the fluid to drain. And that is in your surgical patient. Number 9, we did yesterday is a lot of on sensory system, and we talked few things yesterday about all, but meningeotomy position is on the affected side. Cataract, what position we said? Unaffected side. So underline the word number 9 and highlight the word on cataract, eye shield. Very important that patient must wear eye shield during the nighttime. Avoid lifting weight, no more than 5 pounds. Sometimes they'll say 5 to 10, but remember, no more than 5 pounds. Avoid constipation, any eye surgery patient. Coughing, sneezing, that can lead to increasing the eye pressure. So we avoid that. So cataract surgery, follow-up appointment is important. Eye shield is important. Any pain in the eye, any drainage, any visual problem, you got to notify. But everyone should know eye shield, eye drops, follow-up appointment are important. Next is, the word is, after cataract, thyroidectomy. I want to go over thyroidectomy good, and I want, this is the way we memorize in thyroidectomy. Which patient is going for thyroidectomy? Number one. Which patient is going for thyroidectomy? Which patient? Hyper, yes, and what is the word is called for hyper? Graves' disease. Everyone remember, Graves' disease is hyper. Before patient is going for surgery, what medication you give them? What medication do we give them before surgery? Our hyper patient are PTU, tapazole, Lugol solution. I want everyone remember the word Lugol solution. And I said, how do you give Lugol solution? Mix it in the juice, water, maybe in milk, and use a straw. And pre-op you're giving. Or maybe before patient is going for surgery, that's your medication for hyperthyroid. Number two is, I said, is what are the other one? PTU. What is the other one? Tapazole and radioactive iodine. So everyone remember the drugs here. Number four, radioactive iodine. Why do you give this medication before surgery? Why do we do here? They may give you Lugol solution. Doctor has ordered, patient is scheduled to go for thyroidectomy. And why do we give this medication? Number one, their hormones are very high. What are we lowering here? Thyroid hormones. These are called anti-thyroid medication. So write down the word, you are lowering the hormone. And what are you decreasing here? Risk of bleeding. So what do they use the word? Decreasing vascularity. Everyone should know vascularity means the bleeding. And what are we decreasing here? Vascularity. What are we decreasing here? Hormone. That is your question. What would you teach your patient before thyroidectomy? How to position, support the neck by using their hand when they are turning or they're moving in the bed during position change. Very important that you are teaching them. Now, so those two things are very important. Teaching question, and what do you tell the patient? They are going for thyroidectomy. After the thyroidectomy, your teaching is done. Now patient come back. What do you have in the room? What do we have in the room? Tracheostomy. Very important is what? Trach. Why do we have tracheostomy? Why do we have tracheostomy? Because of low calcium. We don't keep in every patient after surgery tracheostomy. But why here? Because parathyroid gland is on the top of our thyroid gland, and risk is what? This is what we keep in the mind. We know a lot of things, but keep the right thing in the mind. So what is happening here? Calcium level. Because thyroidectomy, and where do we get the calcium? From parathyroid gland. Everyone remember, parathyroid. And it's right closer on the thyroid gland. So when they're going for surgery, patient is coming back, there is a risk for damaging the parathyroid gland. So we must have tracheostomy in the room. Patient is coming back after surgery, and doctor has already ordered calcium gluconate. Why? Because they know if patient has no calcium and patient has symptom of low calcium, nurses don't need to call, they already ordered. Are we clear? And why did they order? Your answer would be to prevent what? The word is called tetany. And what is tetany is twitching of muscle. What is that is? Twitching of the muscle. Everyone remember thyroidectomy? Yes, we are keeping tracheostomy too, but why? Because of the calcium. And what can damage here is the thyroid gland. Now, I want to have, now it says here, is support, we already said shoulder. I'm not done yet. I want you to memorize the right wording for thyroidectomy. So what are the two things we are monitoring immediately after thyroidectomy? Airway and bleeding. What are the complications of thyroidectomy are? What are the thyroidectomy complications are? I want everyone, number one, this, tetany. Everyone should remember the word like this. Tetany is low calcium. What are you monitoring low calcium? We all should know is your chauvinistic and trouser sign for calcium. And what is the patient is doing here? Twitching of the muscle. Number two, a stridor word. Stridor means whenever you see stridor, patient is not able to breathe. Patient is having hard time to breathe. Everyone is okay? So we have stridor here, and patient is not able to breathe here. You are going to notify MD or whoever you have notified, and MD or your RN, whatever in your questions are. This is not good. You cannot keep on monitoring. You got to notify. This is serious. Number three, I want you to know the word hoarseness. They can't talk. How do you check hoarseness? Tell the patient to say, ah. Can't hear the voice. After 4 days, patient says, I can't talk. I have very much hoarseness. Again, your calcium. Number four, thyroid strong. What is the meaning, thyroid strong? Patient turned back in more hyper condition. Thyroxine is gone in the blood. Patient is turning very high, is what here, thyroid strong. Everyone is okay? And what is thyroid strong? What is thyroid strong symptom? If they ask you, they are more hyper. What happened in hyper? Remember the word hot. They use the word hyperthermia. Their blood pressure is high, systolic. They're having diarrhea. Are we clear? More palpitation, more nervousness. Patient is going. What drug do you give for thyroid strong? Back again, but we wrote it earlier. What was the one? What are the one? PTU and Tabazole. Everyone should know for your exam. This is the way, if you memorize, you're going to do better. You can remember a lot of things. But what is it important here in thyroidectomy? Calcium. What happened with calcium? Patient is not going to be able to breathe. And what does it affect? Your heart is not going to be pumping. All the muscles are affected. So everyone is okay? When we say, what is thyroidectomy? Even you guys have done in endocrine with me. But when I'm doing Spiderman, I expect this is the way we need to know your questions and how you will take care of your patient. So everyone, after thyroidectomy, what is the biggest problem? Patient is losing calcium. What do you give immediately? Calcium gluconate, IV. Why? Because they have no calcium. So those are, and remember, you don't tell them to cough, clearing the throat. Mostly all patients, what do we encourage here? Cough and deep breathing. Why? You don't want them to cough and be very more applying the pressure, they can bleed. Supporting the neck is important. So that covers up is thyroidectomy. We'll do one or two more and then we should take a break. And let me cover at least the next one after thyroidectomy, a spinal bifida. Very important, that goes in the peds. I will be doing the peds coming up, I think, sometime next week. But we must know what is spinal bifida in the babies are born. You guys all know, what do you do immediately when the babies have spinal bifida? What do you do? Cover them with normal saline, all right? But what is another word for spinal bifida? Myelomeningeal. Everyone should know myelomeningeal. What happened here in the babies when they're born with myelomeningeal and spinal bifida? In their back, what is coming out? What is the sac is? Meninges. Are we clear? What is the first thing they are out? What is meninges are? Covering of the brain, covering of the spinal cord. From brain till here, we all have same thing, and it pops out, is out. And what else inside there? Number 2, cerebral spinal fluid. What is inside the bag is there, is the spinal cord. And number 4 are the nerves. In the nervous system, nerves are affected. You won't be able to feel sensation. So think about babies who have these meninges, the fluid and the spinal cord and the nerve, they are affected. So what would you see? So first thing we should know is completely is affecting the neuro system. And what do you monitor the patient here is neurological assessment. In your question, what do you monitor babies born with spina bifida? Neurological assessment. What is your neurological assessment here? Babies are okay from above. But what happened the lower part? They are totally paralyzed. Number 1. Number 2, the problem is bladder. And number 3 is the BM. And maybe the legs are weak. What do you assess the baby who's born with spina bifida? Maybe their legs. Maybe they have feet deformity. Their legs are deformed. Also you monitor for hydrocephalus. Are we clear? So what are we assessing here? Hydrocephalus. We are assessing for the feet. We are assessing any dislocation in the hip because it's affecting the lower part. Now immediately they're going to do the surgery. But before surgery, what do? We cover the sac. And what will we cover with? Normal saline. What is the purpose is here? To prevent them from drying. Are we clear? And also keeping it clean. So what are we doing? 2 purposes of doing that is preventing from infection. And number 2, preventing from rupture. So when you are taking care of the sac, keep this thing too in mind. Why? Because what infection can go up there lead to meningitis? Are we clear? So what would be the complication here? Meningitis. Then rupture. If it rupture, we are losing what? Cerebral spinal fluid. So what do you keep in mind when we are taking care of the baby with spinal cord problem or spina bifida? Number 1, be very gentle and make sure you're using what technique? A sterile technique. That may be your question for NCLEX. What gloves are you wearing? A sterile. You've got to prevent infection and be careful from preventing the rupture. Next question. Babies who are born right away, what do you assess? Bladder. What are we assessing? They may not be able to pee. And when they can't pee, what do you do? What is the method is called? When you're applying the pressure and you're emptying the bladder, the word is called Creed method. Everyone should know the word Creed. C-R-E-E-D-S, Creed's method. What is the Creed's method? Without the catheter. Where are we applying the pressure? Lower abdomen, below the umbilicus area, and you're going towards the pubic area. Everyone is okay? Below the umbilicus, so you are applying pressure. What do you assess baby right away? For bladder. What do you teach? So they will do the surgery. Surgery is done. Mother is taking the baby home. What do we teach the mother here when she's taking home? How to catheterize the child. Everyone is okay? How to catheterize. And intermittent catheterization, maybe. Teaching her for preventing constipation. Remember, these babies, they go home, they will not be able to walk. They're wheelchair-bound children, and they can grow, they can live. But what is the biggest problem with these children is UTI. They can't empty the bladder, and they have to have all the time either in and out catheter, Foley catheter, and lead to what? UTI. So everyone, what do you monitor later on? UTI, and write down the word renal failure. For constipation, increase their fiber, fluid. They may need suppository every day. They may have to take enema frequently. So we got to do the teaching. The last thing is I want you to add, these babies are high risk for latex allergy. So add that, latex allergy. So we'll take a quick break for 10 minutes, then we'll continue. And so we